I think the HOPE-3 trial published recently in May 2016 in NEJM is a remarkable trial. Till now, we have many trials that have taken patients with high risk category. But this is a trial that have enrolled patients belonging to the intermediate risk group. Again, the trial has enrolled a population from different ethnic groups. In fact, it has a very high proportion of Chinese and South Asian population, which I think makes the trial results more relevant for our country. This is a 2 by 2 factorial design trial where the where the participants were randomly assigned to receive a placebo or a low dose of candesartan hydrochlorothiazide combination. Then, in the second arm, they were again randomly assigned to receive rosuvastatin 10 mg or placebo. The investigators analyzed the blood pressure changes, the cholesterol changes, and finally the blood pressure and cholesterol levels in those who received both treatments. Now, coming to the results, the trial showed that in the lipid arm, those who received rosuvastatin 10 showed a remarkable reduction in cardiovascular outcome by as much as 25%. This is indeed in accordance with the latest ACC-AHA guideline that recommended statin therapy for those with an ASCVD score of 7.5% or above. In fact, the ASCVD score of the participants of HOPE-3 ranged between 8 and 9%. The real concern about using statin in patients belonging to the intermediate risk group is the side effects, the muscular side effects, rise in liver enzymes, and occasionally the most dangerous side effects of rhabdomyolysis. What HOPE-3 tells us is that probably we need not worry much about these side effects while we treat our patients with rosuvastatin in a dose of 10 mg daily. The side effects are not that significant in HOPE-3, and the muscle symptoms are slightly higher but not significant. If you consider the results of HOPE-3 statin arm, I think you would be more confident in your daily practice in prescribing statin in those patients who comes to you with intermediate risk group. What about hypertension? Now, hypertension treatment is been a topic of heated debate in the aftermath of sprint. As you all know, that sprint has suggested that in high risk individuals, if you lower the blood pressure to less than 120 by 80, the benefit is higher. This challenged the recommendations by most of the recent guidelines like GENC 8, ESC, ASH, and ISH, which recommended a threshold of 140 by 90 in most of the population. Hope 3, I think, is a very important trial which gives us at least some data in resolving this issue. What the hypertension arm in Hope 3 showed. Overall, the hypertension arm failed to show any benefit. But on closer analysis, a post hoc data showed that if the initial blood pressure was more than 140 millimeters systolic, then they are the people who will derive benefit from certain hydrochlorothiazide therapy. In fact, the mean blood pressure in that group was 143 millimeters systolic. But if they have the initial blood pressure lower than 140, then there is no benefit, absolutely no benefit. So, if you take this data from Hope 3 and remember, almost 1/3 of the enrolled population have this blood pressure above 140, probably for the intermediate risk group population, it is still better to stick to the threshold of 140 by 140 millimeter systolic. What is the other important message from Hope 3? The other important message might be use of combination pills. Though Hope 3 has not used a poly pill and the medicines are given separately, but still, if you can combine the trial drugs in a single pill to target the intermediate risk group, this might be more economically viable. So, overall, I think Hope 3 is one of the line breaking trials in prevention that would guide us in future in a large way about how we should go with our intermediate risk patients.